The emergency bay doors slam open. Alarm scream read across the ceiling lights. A gurney rolls in fast, blood soaking through a torn uniform. An unconscious man clutching a radio in his fist like it still matters. Doctors shout orders. Nurses scatter into motion. In the corner, unnoticed, a woman in a plain blue scrub folds a blanket with quiet, mechanical precision. No panic in her hands. No hesitation in her eyes. A young resident snaps at her without looking up. Move. This isn't your department. You're just a nurse. She says nothing. She simply steps toward the gurney, and for 1 second, before anyone can stop her, her eyes scan the wound like she has read 100 just like it before. Somewhere outside, tires screech to a halt. Boots hit the pavement in formation. Nobody in that hospital knows yet. They are about to find out exactly who she is. The alarm clock reads 5:47 a.m. Elena Cross does not snooze. She sits up on the edge of her bed. A small, clean apartment with bare walls, minimal furniture, one window facing the parking lot. The room is functional. Nothing decorates it. No photographs. No evidence of a life outside these four walls. She stands. She goes to the bathroom and washes her face with cold water. No shower. Water and soap. This takes 4 minutes. She looks at herself in the mirror. Dark eyes, steady, lines around them that suggest she has seen things most people never will. She is 52 years old. She looks 70 in some lights, 40 in others, depending on whether she is thinking. Right now, she is thinking. She dresses in her nursing uniform, blue scrubs, white shoes, her employee ID already clipped to her collar. No jewelry, no watch. She wears a simple ring on her left hand, silver, worn smooth by decades of wear. She does not look at it. She stopped acknowledging it years ago. She drives to Fairview District Hospital in a 10-year-old Honda Civic. The radio stays off. She takes the same route every shift. Same timing. Same parking spot in the back lot, farthest from the entrance. At 6:31 a.m., she enters through the staff entrance. The morning shift briefing happens at 6:45 a.m. in the nursing station. 12 nurses, 2 charge nurses, 1 supervisor. Coffee is lukewarm. Someone's phone buzzes. Elena stands at the edge of the group, listening, not speaking. The supervisor, a woman named Patricia with dyed blonde hair and an air of permanent frustration, does not make eye contact with Elena during the briefing. We're running low on staff today. Someone call in. Patricia asks the room. Martin, someone says. Patricia sighs. Okay. Elena, you take the orthopedic unit. Keep your head down. Don't screw anything up. Elena nods once. Patricia moves on to the next item without looking at her. This is normal. Elena pushes a cart of supplies to the orthopedic ward. An older man with a fractured hip, admitted yesterday, scheduled for surgery at noon. A woman recovering from shoulder reconstruction. A teenager with a broken collarbone from a bike accident. Elena checks each room with quiet efficiency. The teenager is awake, anxious, watching the 4-line like it might do something unexpected. Elena enters without announcing herself. She moves to the 4 stand, checks the flow rate, the connection, the tape. All routine. Her hands are steady. They move with a precision that suggests they have done this 10,000 times before. Hurts more when I move, the teenager says. Elena nods. She doesn't smile. She doesn't lie with false cheerfulness. The pain is your body protecting itself, Elena says, her voice low and clear. The medication will help. Don't move your arm above shoulder height for the next 6 hours. After that, movement is necessary. It will hurt. That is part of healing. The teenager looks at her, uncertain whether to trust this statement. Elena checks the wound dressing, makes a note, and turns to leave. Hey, the teenager says. What's your name? Elena pauses. Elena. Thanks, Elena. She nods once and continues her rounds. At 9:15 a.m., she is in the supply room restocking bandages when Dr. Marcus Hammond, a cardiac surgeon with a reputation for arrogance and a habit of treating nurses like custodial staff, finds her. Elena, I need wound irrigation kits. Room 412. I'll bring them now, Elena says. She sets down what she is holding and moves toward him. He does not move out of her way. She stops at the doorway. You know, he says, without looking at her, you really shouldn't try to think for yourself in situations like that. You're a nurse. Follow orders. Don't improvise. It's why we have doctors. Elena says nothing. I'm not interested in heroics from someone in your position. Elena still says nothing. She waits for him to finish, then simply walks around him, not pushing past, not aggressive, just moving, and continues to 412 with the kits. The cost is in her jaw, which tightens for exactly 3 seconds when she is alone in the hallway. Then it releases. Then she continues. This is how Elena Cross absorbs the world that does not see her. And the world, in return, never sees her at all. The television in the hospital cafeteria plays morning news on mute. Elena sits at a corner table, eating a plain sandwich. She is not watching the screen, but she sees it anyway, the way her peripheral vision has been trained to catalog movement and threat. A report about military transport routes, border security concerns, increased activity on Highway 7, which runs east of the city toward the Army base 30 miles away. The caption reads, Unrest near transport corridor. Elena takes another bite of her sandwich. She does not change her expression, but her mind has already begun mapping. The clock reads 11:22 a.m. when Elena notices the first real sign. She is in the central nursing station, updating patient charts on the computer system, when she hears it, a radio frequency that doesn't belong on the hospital's standard emergency band. It's faint, barely audible beneath the normal chatter, but distinct to anyone who knows how to listen. Military band. Encrypted. Not usual dispatch traffic. Elena types without pausing. Her eyes stay on the screen, but she has already logged it. Already noted the time. Already understood that someone in the hospital is monitoring something outside normal protocol. The frequency cuts off after 4 seconds. A nurse beside her, Sarah, new, barely pays attention to anything beyond her own patients. Does not even notice. Elena finishes her chart entry and closes the log. At 11:47 a.m., the ambulance from the Northern Dispatch Center is late. It should have arrived at 11:15 a.m. The patient, a woman admitted through the ER with acute appendicitis, was scheduled for immediate surgical transfer to the larger teaching hospital across town. Protocol is clear. Transfer time is predictable. The ambulance from County General never runs more than 5 minutes late. It is now 32 minutes late. Elena hears the call come through dispatch on the overhead speaker. Fairview, this is County Dispatch. ETA 15 minutes. Traffic incident on the main route. Traffic incident. At 11:47 a.m. On a Tuesday, on a highway that sees moderate traffic. Elena is at the nursing station when she hears this. She does not react. She simply makes a mental note of the exact time. Patricia, the charge nurse, frowns at the speaker and makes a note on her clipboard. No one else seems to notice the oddness. Elena does. At 12:34 p.m., Elena is in the orthopedic supply closet when she hears Patricia's voice through the door. She is on the phone, in the hallway just outside, speaking in a low, tense tone. I understand, Patricia is saying. No, I'm not calling security. I know the protocol. Yes, I will. If anyone asks, I'll say it was a routine staffing call. A pause. I have to go. Someone will see me. The phone clicks off. Elena stands very still inside the supply closet, holding a box of sterile bandages. She hears Patricia's footsteps move away down the hallway. Elena processes this information with the same methodical precision she applies to everything else. A staffing call. Not about staffing. A protocol she is aware of that involves discretion. A conversation someone does not want others to hear. The possibility space is small but specific. Hospital administration has been notified of something that requires preparation but cannot be discussed openly. Elena continues her work. She restocks the shelves. She does not hurry. She does not change her pace. When she exits the closet, she makes a decision. At 1:15 p.m., Elena walks to the trauma bays in the basement level. Trauma Bay 1 is set up for a routine case. Trauma Bay 2 is empty, clean, but not actively prepared for incoming patients. In standard protocol, it would be cleared and prepped only when dispatch confirms incoming trauma. Elena finds the tech responsible for the bay, a man named David who is scrolling through his phone. Bay 2, Elena says quietly. Can you help me set it up? David looks at her, mildly confused. No incoming, he says. I know, Elena says. But it should be ready anyway. David frowns. That's not protocol. Elena does not argue. She simply moves to the supply cabinet and begins pulling out what would be needed for a high-acuity trauma case. Sterile instruments, blood pressure cuff, cardiac monitor pads, oxygen equipment. for lines. The works. Hey, David says, standing up. You can't just. I'm helping you prepare, Elena says, her voice even. It's not against protocol. It's redundancy. It makes sense. David looks like he might argue further, but there is something in Elena's tone, not aggressive, just certain, that makes him decide against it. He joins her without further comment. Together, they prepare Trauma Bay 2 to full operational readiness. It takes 23 minutes. When they finish, David does not understand why they did this. Elena does not explain. She simply steps back, reviews the bay with her eyes, and nods once. Then she returns to her assigned floor. By 1:38 p.m., Trauma Bay 2 is ready. No one knows why. Not yet. The dispatch call comes through at 2:14 p.m. It is not framed as an emergency at first. It is framed as a redirect. Fairview District, this is County Dispatch. We have multiple incoming trauma cases being diverted from base hospital due to capacity. ETA approximately 12 minutes. Multiple GSW, at least one critical. Please advise available trauma beds. GSW. Gunshot wounds. Elena, who is on her way back from the orthopedic floor, hears this through the overhead speaker in the hallway. She stops walking. She does not turn around. She simply listens. Patricia's voice crackles back through the system. Copy that. We have 2 trauma bays ready. What's the count? Initial count is 4 confirmed. 1 officer-level priority. Details are still coming in. Military transport incident. Security implications. Keep this close. The dispatch line goes dead. Elena continues walking, but her pace has shifted. Not faster. Deliberate. She changes direction toward the basement stairs without breaking stride. The ER erupts 8 minutes later. The first ambulance screams through the bay doors at 2:22 p.m. Sirens wailing. Red lights painting the ceiling in urgent pulses. Paramedics are shouting numbers. Blood pressure dropping. Respiratory distress. 2 units of packed red blood cells already running. A man in a military uniform, half his right side wrapped in field bandages soaked through with blood. Trauma Bay 1 receives him. 2 minutes later, a second ambulance pulls in. This casualty is conscious, in shock, arm hanging at an angle that suggests compound fracture. He is crying. Rage and pain mixed together. Trauma Bay 2 receives him. Elena is already there when he is rolled in. She does not question how she knew to be there. She does not explain it to anyone. She is simply present, moving with the paramedics, reading the wound assessment on the fly, noting the vital signs the EMT is calling out. Room, she says to David, who is standing frozen near the equipment. David snaps back to awareness and helps her position the gurney. A young resident, Dr. Sarah Chun, second year, still learning, appears in the doorway, looking lost. What do we have? She asks, her voice already elevated with stress. Blast fragmentation, Elena says, not looking away from the patient. Compound fracture, right humerus. Possible spinal involvement from impact. He's conscious. Vitals are unstable. Dr. Chin nods, not fully processing, and starts calling orders that are already being executed. Elena does not acknowledge the resident. She simply moves through the trauma sequence with the precision of someone who has done this 1,000 times in environments far more compromised than a hospital. She establishes a second 4 line while the resident is still formulating her assessment. She positions the patient to prevent aspiration without being told. She catches the monitor reading before anyone else sees it and adjusts the oxygen flow accordingly. All of this happens in the space of 90 seconds. By 2:31 p.m., 3 more casualties have been brought in. The hospital is no longer functioning according to protocol. It is in crisis mode. Dr. Marcus Hammond rushes past Elena without looking at her. Patricia is on the phone with hospital administration, her voice tight. Nurses are pulling in from other departments. The waiting room is filling with military personnel in dress uniforms, armed security, people making quiet phone calls. The air has changed. Elena has seen this before. Not here, but in places where the stakes were real and the chaos was part of the terrain. By 3 p.m., the situation stabilizes into controlled panic. 1 casualty is in surgery. 2 are stabilized in ICU beds. 1, a young soldier, barely 25, is in Trauma Bay 2 with Dr. Chun, who is managing his care with growing confidence now that Elena has set the foundation. Elena is changing the dressing on his wound when the soldier looks at her, his eyes glassy from pain medication and asks a question. Are you a doctor? He says. No. Elena says, not looking up. I'm a nurse. You move like. He trails off, the medication pulling his thoughts apart. Elena finishes the dressing and checks the monitor. Like what? She asks, though she does not expect an answer. Like you know what you're doing, he says. Elena does not respond to this. She simply moves to the 4 pump and adjusts the pain medication dosage based on his heart rate and respiratory effort, a decision that technically requires physician approval, but which she executes anyway because she can see he is suffering and the numbers tell her it is safe. Dr. Chun, reviewing charts at the station outside the bay, does not notice. If she had, she would have corrected Elena for acting outside her scope. Elena does not wait for approval she knows will not come. By 3:47 p.m., the immediate crisis has moved past its peak. The surgeon comes out of the OR. One casualty will survive. Prognosis uncertain on complications, but the bleeding is stopped and the vital organs are intact. A colonel in dress blues stands in the hallway, speaking quietly with hospital administration. Patricia approaches Elena as she is restocking supplies in Trauma Bay 2. That was good work, Patricia says, almost grudgingly. Elena does not look up. We're lucky you were in the right place. Elena continues what she is doing. Anyway, keep moving. We're still short-staffed. Patricia walks away. Elena finishes restocking the bay. She does not acknowledge the compliment because she understands what it really means. Gratitude mixed with the assumption that competence in crisis is somehow unusual for her. It is not unusual. It has always been there. No one simply looked close enough to see it. Until now. And even now, they only see it in the context of crisis. They do not see it as who she is. They see it as what she did today. Elena steps back, surveys the cleaned and restocked bay, and moves on to her next task. The day continues. The crisis recedes into a new normal, and Elena Cross returns, once again, to being someone no one notices. The soldier's name is Lieutenant James Erickson. He regains full consciousness at 4:52 p.m., and the first thing he does is try to kill the 4 line in his arm. Get this out, he says, his voice hoarse and edged with the particular anger of someone who has lost control of his body. Get it out now. Dr. Chun, who is reviewing his labs at the bedside, gently takes his hand. Lieutenant, you need the fluids. Your pressure is still dropping. I don't care. Erickson snaps. I don't care what my pressure is. Get it out. He pulls his arm away from her with enough force that the 4 line flexes, but does not dislodge. Elena is in the room, changing the 4 bag. She does not react to his outburst. She simply finishes securing the new bag, checks the flow rate, and waits. Lieutenant, Dr. Chin says, her voice taking on the careful tone of someone speaking to a child. I know you're uncomfortable, but... Uncomfortable. Erickson laughs, a sharp, bitter sound. I'm not uncomfortable. I'm infected with incompetence. You people don't know what you're doing. Elena steps back from the 4 stand. Erickson's eyes find her. Especially you, he says, his gaze locking onto her blue scrubs like a targeting system. What's your name? Elena does not hesitate. Elena. Elena what? Cross. Erickson nods, as if this confirms something he already suspected. You're a nurse, right? Yes. Of course you are, he says. Because I was patched up in the field by people who actually knew what they were doing, and now I'm in a hospital surrounded by people playing dress-up. Elena does not respond. How much training do you have? Erickson asks. 6 months? A year? For years, Elena says quietly. Plus continuing education. Right. Erickson says, his voice dripping with contempt. 4 years of watching someone else do the real work. That's not training. That's observation. Dr. Chin's face flushes slightly. She opens her mouth to say something defensive on Elena's behalf. Elena raises a hand, barely a gesture, that stops her. She turns back to Erickson. Your dressing needs to be changed every 4 hours, Elena says, her voice steady and clinical. The wound is clean, but infection is a risk for the next 72 hours. I need you to keep the arm immobilized. Movement will compromise the healing, and the pain will increase. Erickson stares at her. I don't care about your nursing schedule, he says. I care about getting out of this bed and back to my unit. You won't be cleared for duty, Elena says. Not for 6 weeks minimum. That's not your call. No, Elena agrees. But it's medical fact. She moves to adjust his pillow without asking permission. Erickson flinches, but allows it. She positions it to support his injured arm, distributing the weight evenly to reduce the strain on the fracture site. How bad was it? Erickson asks suddenly, the anger draining from his voice. Out there. The convoy. Elena does not answer immediately. I can't discuss that with you, she says. Because I'm just a soldier? Because it's not my information to share. Elena checks the monitor. His heart rate is elevated, pain, adrenaline, stress hormones, all running high. She increases the pain medication by 0.5 milligrams, a minor adjustment that falls technically within the standing order but pushes toward the top of the allowed range. I'm not going to die here, Erickson says, more to himself than to her. No, Elena says. You're not. She says this with such absolute certainty that Erickson actually looks at her, really looks at her, for the first time. There is no doubt in her voice. No false comfort. No nurse speak designed to manage his emotions. Just fact. He wants to say something else, something cutting, but the medication is hitting his system and his eyelids are becoming heavy. You should rest, Elena says. Don't tell me what to do, Erickson says, but his voice is already slurring. Within 4 minutes, he is asleep. Dr. Chun and Elena step out into the hallway. Chun is quiet for a long moment, then speaks. I'm sorry he spoke to you that way, she says, somewhat formally. It's fine, Elena says. It's not fine, Chun insists. He was disrespectful. You didn't deserve that. Elena glances at her. He's in shock, Elena says. Pain, fear, loss of control. His aggression isn't about me. It's about the fact that his world just changed. Chin nods, understanding this intellectually. That was good instinct, Chin says, referring to the increased pain medication. Technically, I should have ordered it, but you read the situation better than I did. Elena does not acknowledge the compliment. He'll sleep for 3 hours, Elena says. Monitor his vitals every 30 minutes. If his pressure drops below 105 systolic, call me immediately. I will, Chin says. Elena walks away down the corridor. But what Dr. Chin does not see, and what Erickson will not remember when he wakes, is the way Elena had calibrated every movement, every decision, and every word with the precision of someone who has managed far worse than a wounded lieutenant's anger. She had not defended herself. She had not fought back. She had simply absorbed his disrespect and then, with absolute competence, had done exactly what was needed to ensure his survival. It was restraint. It was authority. It was something that should have been invisible to everyone in that hospital. But somewhere in the building, someone was watching. Someone who understood what they were seeing. And that person was beginning to wonder. The call comes at 5:38 p.m. Elena is restocking supplies in the ICU when Patricia finds her. We have an incoming, Patricia says, moving quickly. Major trauma. Multi-system failure. They're 10 minutes out. Elena nods and follows her. By the time they reach Trauma Bay 1, the staff is already assembling. Dr. Marcus Hammond, the cardiac surgeon from this morning, is there. A resident. 2 nurses. The whole machinery of crisis response, preparing itself. Elena positions herself at the edge of the bay, close enough to help, far enough back to not be in the way. This is her place. She understands it. The ambulance arrives at 5:48 p.m. They pull out a man, 60s, gray-bearded, wearing the remnants of a military dress uniform beneath the emergency blanket. His left side is crushed, not just wounded, crushed. The paramedic is calling out numbers that sound like code for dying. Tension pneumothorax, possible hemothorax, the paramedic shouts. Crushed pelvis. We decompress the chest on scene, but he's losing pressure again. 2 units running, 2 more in transit. Dr. Hammond takes the lead immediately. Get him on the monitor. I need a chest x-ray stat and page orthopedic. We're looking at pelvic reconstruction. The team moves into practiced chaos. Lines are established. The monitor screams with warning tones. The patient's blood pressure is 82/56 and dropping. Elena watches. She sees what is happening before anyone else articulates it. The crushing injury to the left side has caused massive internal bleeding, not just from the obvious wound, but from the organs beneath. His spleen is probably gone. His left kidney is definitely compromised. His ribs are fractured in multiple places, and at least one has likely punctured something vital. And his pelvis. A crushed pelvis means massive pelvic bleeding, the kind that cannot be stopped in an operating room if you don't reach it in time. The kind that kills soldiers on battlefields because there is no time and no way to get them to a hospital alive. Except this man is in a hospital. We need pelvic stabilization now, Elena says quietly. No one hears her. Or they hear her, but do not register that it came from the nurse standing against the wall. The man's pressure drops to 78/52. We're losing him, the resident says, panic creeping into her voice. Hammond is scanning the imaging as it comes in. His jaw tightens. Get him to, or he says. We need to open him up and find the source. His pressure won't support surgery, the anesthesiologist says, stepping forward. He's too unstable. We'll lose him on the table. Hammond stops. He processes this. The math is brutal and clear. This man is bleeding out internally, but his body cannot tolerate the physiological stress of surgery. Trying to fix the problem will kill him faster than the problem itself. It is a moment where medicine reaches its limit. Elena steps forward. Pelvic binder, she says, her voice cutting through the moment. And a resuscitative thoracotomy. Everyone looks at her. Hammond's expression is almost amused, as if a custodian has just offered cardiac surgical advice. This is not the time for, he begins. His pelvis is fractured in multiple places. Elena continues, not raising her voice, just continuing with clinical precision. Stabilizing it will reduce the internal bleeding significantly, and his left lung is compromised, but salvageable if you decompress it now, before you open him up. And who exactly are you to make that assessment? Hammond asks, not hostile, just dismissive. The patient's pressure drops to 74/48. Elena does not answer the question. Instead, she moves to the equipment cabinet and pulls out a pelvic binder, a specialized device most trauma nurses have seen once or twice in their careers, but never actually used in true crisis. She has used it many times. The binder, she says, placing it on the gurney beside the patient. Now, by 6:15 p.m., the crushed patient is in surgery. The resuscitative thoracotomy worked. The pelvic binder reduced the internal bleeding enough to buy time. Hammond is now in the or with a trauma team, racing against infection and tissue death. Elena has moved back to the peripheral role everyone expects of her. She is updating the surgical log when she notices the shift in the hospital's operational security. It is subtle, the kind of thing that only someone trained to read security protocols would catch. The colonel in dress blues, the one she saw in the hallway earlier, is now stationed near the ICU entrance. Not standing casually, standing with purpose. Armed security personnel have been quietly positioned at the main ER entrance and the stairwells. Someone has decided that access to this hospital needs to be controlled. Elena does not react. She simply continues her work and observes. At 6:47 p.m., Patricia pulls her aside. There's a meeting in the administrator's office, Patricia says quietly. Just charge nurses and senior medical staff. But I need you to do something for me. Elena waits. I need you to check every exterior door on this floor. Make sure they're locked. Don't ask why. Don't tell anyone. Just check and report to me. Elena nods. She understands now. Security is not just increased. Security is being re-implemented because there is a credible threat. How long? Elena asks. Patricia's eyes widen slightly at the question, at the fact that Elena is asking what everyone else would need to have explained to them. I don't know, Patricia says. Just do it. Elena moves through the hospital with her supply cart as cover. She checks the loading dock entrance. Locked. Good. She checks the emergency stairwell exits on every floor she has access to. All locked. She checks the maintenance corridor that connects to the basement. This one is not locked. She locks it herself, using the master key she has never used before, but which she knows is kept in the nursing station. She is not supposed to have that key. No one will notice that she does. As she moves through the maintenance corridor, she catalogs the vulnerabilities the hospital's security team has likely missed. There are three separate entry points where someone with knowledge of building codes could access the basement without going through main entrances. One through the old pneumatic tube system, one through the HVAC access panel, one through the pharmacy delivery entrance, which locks from the outside, but can be accessed from inside using the emergency release. These are not security oversights. These are building code requirements. But they are vulnerabilities in a crisis situation. Elena makes a mental note of each one. At 7:12 p.m., she reports to Patricia. All secured, Elena says. Patricia nods, relieved. Thank you, she says, and she means it. Elena does not tell her about the vulnerabilities. Patricia would not understand what to do with that information, and it would only cause alarm without providing solution. At 7:34 p.m., the situation crystallizes. 2 federal agents arrive, Bureau of Alcohol, Tobacco, and Firearms, which means the ambush was not a random military incident. It was a targeted action. Someone was transported in that convoy, and someone wanted to stop that transport. Now that person is in this hospital. Elena overhears fragments of the conversation between the agents and hospital administration in a hallway she is quietly cleaning. She is invisible again, which means people speak freely around her. Primary target was the colonel, one agent says. We believe there's a secondary objective. Eliminate any witnesses or intelligence he may have shared. Here, in the hospital, the administrator asks, his voice strained. We don't think so, the other agent says. But we can't rule it out. We need to lock this place down until we have assurances. Elena continues mopping the floor. She does not change her pace, but her mind is already moving through the scenario they have laid out. If the ambush was targeted at a colonel, and if there is concern about secondary objectives, then the threat is specific. Surgical, not random violence, but tactical assassination, which means whoever planned the ambush knows the hospital's layout, which means they may have already scouted the location, which means they know about those 3 vulnerabilities Elena identified. At 8:01 p.m., Elena requests to speak with the security director. She approaches him in the hallway near the ICU, a man named Director Foster, who arrived with the federal agents. I need to show you something, Elena says quietly. Foster looks at her with the particular dismissal reserved for hospital staff who are not doctors or administrators. Not now, he says, already moving away. The maintenance corridor, Elena says. 3 entry points you've secured the primary accesses for, but not the secondary ones. Foster stops. He turns back to look at her. Who are you, he asks. Elena Cross. Nurse. I work here. I know the building. Thank you for the concern, Foster says, his tone suggesting the conversation is over. But we have security protocols. You have security protocols for doors that are watched, Elena says. Not for pneumatic tube access or HVAC panels. Foster's expression shifts slightly. We'll take it under advisement, he says. He walks away. Elena does not push further. She has said what she needed to say. Whether he listens or not is now his decision, and his responsibility if something goes wrong because of what he did not do. This is the cost of being someone no one listens to. You speak the truth anyway. You live with being ignored. And sometimes, people get hurt because of it. Elena returns to her duties, knowing that the hospital's security is incomplete, knowing that the threat is real, and knowing that no one with actual authority will believe a nurse who sees what they cannot. She will have to be ready for what comes next, because something will come. It always does. Elena does not sleep that night. She sits in her apartment, the lights off, and watches the window where the parking lot lights cast long shadows across her walls. She has done this before. The waiting, the calculation, the knowledge that a decision point is approaching. She has not done this in 12 years. The last time was when she decided to leave. At 2:47 a.m., she makes coffee. Black. No sugar. She sits at her kitchen table, the same one she bought at a thrift store in 2011, the year she retired from active duty, and she allows herself to think about what comes next. Foster will not have listened. Hospitals do not expect security advice from nurses. It is the nature of hierarchy, and hierarchy keeps people alive by creating clear chains of command. It also keeps people dead when those chains fail. Elena knows what will happen. She has read the pattern 100 times in military operations, in intelligence briefings, in after-action reports. The threat will come through one of those secondary access points she identified. It will probably come between midnight and 4 a.m., the window when security consciousness is lowest and the hospital's operational tempo is reduced to skeleton crew. It will target the patient in the ICU, the colonel, the primary target from the ambush. And the hospital's current security protocols will not stop it. Elena knows this the way she knows her own breathing. She can see it happening the way someone might see a memory. She could call the federal agents. Tell them about the vulnerabilities. Stay anonymous. Give them the information. Let them do their job. But they will ask how she knows. And when she explains, they will want to know more. And more leads to questions about her background, her experience, why a nurse knows about tactical building access and security protocol gaps. And those answers lead to records, and records lead to names, and names lead to the past she spent 12 years burying. Elena stands and walks to her bedroom. In the closet, under a box of old paperwork, there is a photo album she has not opened since 2011. She does not open it now, but she acknowledges it is there. She acknowledges the person in those photographs, younger, in uniform, standing beside people who called her Colonel. Standing beside a man with kind eyes and the kind of smile that suggested he believed in something larger than himself. That album is why she is a nurse now. That album is why she cannot be found. At 4:15 a.m., Elena makes her decision. She will go to work. She will be present when the threat arrives, and it will arrive. She is certain of this. She will act on her knowledge in the moment, using everything she knows, everything she is trained to do, everything she has spent 12 years hiding. And when it is over, there will be no remaining ambiguity about who Elena Cross is. The quiet life ends. She accepts this. She arrives at the hospital at 5:22 a.m., 2 hours before her shift begins. She uses her employee badge to access the staff entrance. No one questions her. Early shifts happen. People work odd hours. She goes directly to the security office in the basement. Director Foster is not there. A younger guard named Peterson is on the night watch. "I need to show you something," Elena says. Peterson looks at her, a nurse, in scrubs, at 5:22 in the morning, asking to see security vulnerabilities. "I can call the director," Peterson says carefully. "Do that," Elena says. "But also listen to what I'm about to tell you. Because if you don't, someone is going to die in this hospital in the next 6 hours." Peterson studies her. Something in her voice, something absolute, something that carries the weight of experience, makes him take her seriously. He calls Foster. Foster arrives at 5:41 a.m., irritated at being woken. Elena walks him through the building. She shows him the pneumatic tube access in the basement, a rusted panel that could be forced open by someone with tools in 10 minutes. She shows him the HVAC access route, a ladder hidden behind maintenance equipment that leads to every floor of the hospital. She shows him the pharmacy delivery entrance, the emergency release that can be activated from inside. And then she stops. "This is not standard nurse knowledge," Foster says, studying her. Elena does not respond to this. "How do you know this?" Foster asks. Elena meets his eyes. "Because I was trained to see it," she says. Foster is quiet for a long moment. "Military?" he asks. Elena does not confirm or deny. "This threat is specific," Elena continues. "Tactical. Someone wants the colonel dead. They know this hospital. They've planned this. And your current perimeter will not stop them. Why are you telling me this?" Foster asks. Elena considers the answer. "Because the alternative is watching people die," she says. Foster nods slowly. He understands what she is doing. He understands what it costs her to do it. "If I secure these access points, I'm going to have to explain how I know about them," Foster says. "Yes," Elena says. "That's going to create questions." "Yes." "About who you are." "Yes." Foster is quiet again. Then he picks up his radio. "I need a security team," he says. "Basement level. We have additional vulnerabilities to secure. And I need it done quietly and fast." He looks at Elena. "Stay," he says. "And then we talk. Because whatever you are, you just stopped something bad from happening." Elena nods. She has crossed the line. There is no stepping back now. The quiet life is over. The threat comes at 2:33 a.m. Elena is in the ICU, ostensibly checking on a post-operative patient, when she hears it, the soft metallic sound of the HVAC panel being forced open in the basement access shaft. Foster's team has been in position for 6 hours. Elena moves to the security station near the ICU entrance, a location that should alert Foster immediately. But before she can reach the radio, she hears something else. Gunfire. 2 shots. Muffled by suppressor. Distant enough to be mistaken for something else if you are not listening for it. 2 of Foster's security team are down. The threat is not just someone trying to access the building. The threat is armed and willing to engage. Elena does not hesitate. She moves to the ICU pharmaceutical storage and opens the locked cabinet using her employee code. She pulls out a syringe and a bottle of medication, something that will not kill someone, but will render them unconscious within 40 seconds of 4 injection. She has 7 minutes, maybe 8, before the threat reaches the colonel's room. Elena positions herself in the stairwell, the one the threat will use because it is the fastest route to the ICU from the basement access point. She stands against the wall, out of direct sight lines, the syringe concealed in her sleeve. Her breathing is steady. Her heartbeat is controlled. This is muscle memory. This is a version of herself she has not accessed in 12 years. At 2:39 a.m., a man enters the stairwell from below. He is armed, a 9mm pistol with suppressor, held low but ready. He is moving with purpose, with training. This is not an amateur. He climbs the stairs with tactical awareness, checking angles, staying alert. He does not see Elena until he is 3 feet from her. By then, it is too late. She moves with controlled violence. Not rage, not desperation, just precise action. She disarms him with a motion that breaks his grip without breaking his arm. The pistol clatters to the concrete floor. She steps into him, neutralizing his ability to strike back, and injects the medication into the carotid artery with the accuracy of someone who has done this 1,000 times in training. His eyes widen. He tries to move, but the drug is already entering his bloodstream. Elena lowers him to the ground as his consciousness fragments and fails. He is unconscious within 38 seconds. Elena secures the weapon, clears the stairwell, and continues moving. At 2:42 a.m., she reaches the ICU. Foster is already there, along with federal agents who apparently have been watching the stairwell cameras. They saw what Elena did, though they cannot yet process what they saw. There's another one, Foster says, his voice tight. Ground level. Trying to access through the delivery in trance. Elena does not stop moving. She exits the ICU, moves through the emergency corridor, and reaches the delivery area in under 90 seconds. The second threat is using a blowtorch to cut through the emergency door mechanism. Elena does not use the syringe this time. She moves behind him, and with the same controlled precision she employed in the stairwell, she disables him. A pressure point strike to the brachial plexus that drops him instantly, his arm going numb and useless. He drops the blowtorch and spins to face her. She steps inside his guard and executes a takedown that is textbook military training, controlled, efficient, leaving him conscious but unable to offer further resistance. 2 federal agents appear in the corridor behind her. They have their weapons drawn, but Elena is already moving away from the threat, her hands raised, her own weapon secured. By 2:51 a.m., both threats are secured. The hospital is in controlled chaos. Lockdown initiated, staff alerted, medical personnel securing patients. Elena stands in the hallway outside the ICU, her heart rate elevated but controlled, her hands steady. A man in an army dress uniform approaches her. A colonel, insignia visible, clearly high-ranking. He is not the wounded colonel from the ambush. He is someone else. He approaches Elena slowly, studying her face. Recognition crosses his expression. Colonel Cross, he says, his voice quiet but clear. Elena does not respond. The colonel looks at Foster, at the federal agents, at the nursing staff who have gathered in the corridor. Then, without a word, he steps forward. He stands at perfect attention, and he salutes. Not a casual gesture. A full military salute, the kind rendered to a superior officer, the kind that acknowledges rank and respect and service. His hand rises to his temple, crisp and formal, held for exactly 3 seconds. Then he lowers it. "Thank you, Colonel," he says. Elena does not return the salute. She simply nods once. Around them, the hospital staff begins to understand. They are watching it happen. The moment when hierarchy reveals itself, when the woman they dismissed, the one who was just a nurse, steps into the authority she has been carrying all along. Dr. Hammond stands in the doorway of a patient room, his expression processing the impossible. Patricia, the charge nurse, simply stares. Dr. Chen looks at Elena as if seeing her for the first time. At 3:04 a.m., federal agents begin their debrief. Elena gives them the facts. The reconnaissance, the threat assessment, the actions taken. All of it is documented, recorded, filed into official channels. She does not minimize what she did. She does not apologize for stepping outside civilian protocols. She simply states what happened and why it was necessary. By 4:15 a.m., she is informed that she will need to make a formal statement to the Army's Office of Special Investigations. By 5:30 a.m., when her shift is supposed to start, It is clear that Elena Cross's quiet life is officially over. The salute did that. 12 years of concealment ended in 3 seconds. The news identifies her by morning. Retired Army colonel working as ER nurse stops assassination attempt. Elena sees the headline at 6:47 a.m. in the waiting area of the Office of Special Investigations. She does not read further. By 9:15 a.m., she is at Fairview collecting her things from her locker. A photograph, a spare pair of shoes, 3 coffee mugs, 12 years, compressed into a cardboard box. Patricia finds her there. The staff wanted you to know we're grateful. Patricia says carefully. I did my job, Elena says. You did more than that. Elena turns to face her. I did what was necessary to prevent deaths. That's not heroism. That's responsibility. Patricia nods, understanding that this woman never needed her approval. Elena walks past Trauma Bay 1. Dr. Hammond sees her, opens his mouth, but Elena simply nods once and continues. There is nothing to say. Acknowledgement now would only be performative. In the ICU, Lieutenant Erickson is awake and alert. The news says you stopped someone from killing a colonel, he says. I stopped a threat, Elena says. You knew exactly what you were doing that day with my dressing, Erickson says. I was disrespectful to you. I'm sorry. Elena nods once. Your recovery protocol is 4 weeks supervised, Elena says. Follow it exactly. I will, Erickson says. Elena moves toward the door. Colonel, he says. Thank you. Elena does not turn around. Thank your surgeons. They saved your life. By 11 a.m., she is in her apartment. She pulls out the photo album, images of a younger woman in Army uniform, a man with kind eyes beside her. Deployments. Ceremonies. A life before this one. She studies it without expression, then closes it. That person was real, but Elena Cross chose to leave her behind. She has no regret about that choice, even now. At 12:47 p.m., Foster calls. The investigation is complete. You're cleared. The Army wants to know about consulting work. Private security. Training. No, Elena says. I'm not interested in going back, Elena says. Not in any capacity. Foster understands. He ends the call. At 3:15 p.m., the hospital calls asking if she will return. Elena requests 1 week to consider. At 7:31 p.m., she calls back. I'm ready to return to my position, Elena says. When can I start? Tomorrow night. The administrator says, relief in his voice. Tomorrow night is fine, Elena says. At 7:45 p.m. the next evening, Elena arrives at Fairview. She parks in her usual spot, far from the entrance. She changes into her scrubs. The nursing station briefing begins. Patricia nods at her. The other nurses regard her differently now. There is recognition, awareness, respect. Elena does not acknowledge any of it. You're taking orthopedics? Patricia says. Standard assignment. Elena nods. It is the same role, the same floor, the same patients who do not know who she is. Nothing has changed. Everything has changed. At 11:47 p.m., an elderly woman asks Elena to sit with her because she cannot sleep. Are you the one from the news? The woman asks. Yes, Elena says. My grandson is a soldier in Afghanistan. He writes that people like you are why he feels safe. Elena adjusts the woman's blanket. Rest, Elena says. She continues her rounds. At 6:15 a.m., as her shift ends, Elena stands in the hallway. The place where she hid. The place where she helped people while remaining unseen. The place where her past caught up with her. She could leave, find another hospital, start another quiet life. But that would be running. And Elena Cross has done enough running. She understands now. The quiet life was never the point. The point was the work. The people who got better because someone knew how to save them was there. The restraint. The discipline. The kind of strength that does not need to be seen to be real. That person was always Elena Cross. The world simply did not know it until now. She clocks out. She drives home and sits at her kitchen table with black coffee. In 16 hours, her next shift begins. She will go back. She will work. She will do it exactly the same way she always has. Quietly, without fanfare, without expectation, with the absolute certainty of someone who knows exactly who she is. Yindi.